Hi, my name is Polly Pittman. I'm a professor in the School of Public Health at the George Washington University, and I direct the Fitzhugh Mullen Institute for Health Workforce Equity. Welcome to the Mullen Institute webinar series on emergency health workforce policies to address COVID-19. This session will focus on expanding scope of practice as one strategy states can use to maximize the current workforce. Scope of practice is not a new issue. Basic principle of staffing is to use professionals at the top of their education and licensing. This is both to maximize efficiency and to avoid the frustration at a personal level of the professionals. Most policy debate on this issue has focused on advanced practice nurses, although there's a growing body of research on other professions as well. The situation today makes the issues of efficiency and of low staff morale all the more important and more urgent. Today, we're very fortunate to be joined by two national experts from California and Washington, respectively, who have deep knowledge of scope of practice regulations across nursing and the allied health professions. We'll be talking about emergency measures that states can take to allow healthcare organizations greater flexibility in the way they deploy their personnel. Dr. Joanne Spetz is the Associate Director of Research at the Health Force Center at UCSF and the Director of the HRSA-funded Health Workforce Research Center that focuses on long-term care. Dr. Spetz is a professor in the Philip R. Lee Institute for Health Policy Studies in the Department of Family and Community Medicine at the School of Nursing in UCSF. Joanne and her team are working with the California state government to identify workforce policies to address COVID-19. Dr. Bianca Frogner is an associate professor in the Department of Family Medicine in the School of Medicine at the University of Washington. She's the director of the UW Center for Health Workforce Studies and deputy director of the Primary Care Innovations Lab, both of which are housed in the Department of Family Medicine. Bianca and her team are working closely with the Washington state government to identify workforce policies to address COVID-19. So happy you could both join me today. Joanne, I'd like to start with you. Could you give us a brief explanation of how state scope of practice laws are made and why they affect the ability of providers to meet the COVID patients' needs right now? And in a sense, talk as well, if you can, about how these regulations are modified in normal circumstances as well as in the current circumstance.
Sure. Scope of practice regulations are generally established by legislatures and then are implemented by state licensing boards or other state agencies such as the Department of Public Health or a Department of Healthcare Services. The scope of practice regulations dictate who is allowed to work and fulfill certain kinds of roles, what tasks they're allowed to do, and under what circumstances they can do those tasks. So the scope of practice regulations might control the locations in which a person can practice, such as a paramedic practicing in pre-hospital care and then having a certain range of sites in which they are allowed to perform that care. Or you might have an advanced practice nurse being controlled in terms of, do they need to have a supervisor? What is their written protocols that they might be required to practice under, or can they practice autonomously? So these kinds of laws are generally changed through state legislation. Depending on the scope of the state legislation, sometimes the licensing boards do have some autonomy to put forward regulations under the broad banner of whatever the legislature has passed.
Great, thanks. So Bianca, scope of practice restrictions are an issue for many professions. Given the current situation, if there was one or two professions that you think could contribute greatly to attending to the needs of COVID patients and would require some kind of expansion of scope of practice, what professions do you think are most important right now for expansion of scope?
Well, there's quite a few, thank you for that question. There are quite a few professions who are definitely playing a very important role on the front lines right now. You know, I think one that doesn't tend to get talked about very often are paramedics. They're the ones who tend to be on the ground in the community responding to emergency calls. And their typical role is to transport patients from the community into the hospital, usually to the emergency room. And recently, there are new protocols being put into place to allow the increase in scope of practice for paramedics to be able to practice across multiple settings, in particular working with skilled nursing facilities to help triage patients to identify those who have COVID-19 or not, and then to help transport patients between these settings, which has not been a typical part of their scope. One other profession I'll also mention are physician assistants. They also tend to be on the front lines, often working underneath the supervision of a physician. And states are quickly moving to try to remove those supervision requirements so that physician assistants can work independently, as well as be able to do things like actually make diagnosis based on tests that are coming back. And so we're also seeing physician assistants play a greater role also in delivering care via telemedicine. And again, usually that's with the supervision of a physician, and we're seeing those restrictions get removed.
Interesting. And Joanne, you are an expert on the nurse workforce, among other things. Within nursing, we have all kinds of different degrees with all kinds of scope of practice restrictions. Which ones are the most important to be thinking about changing now?
Oh, that's a great question. You know, I think the areas in which I've heard the most discussion have been around nurse practitioners and nurse midwives, who in many states are required to have a collaborative or supervisory relationship with a physician. In some cases, there are limits on how many of advanced practice nurses a physician can supervise. And depending on the state, there might be requirements about having written, kind of pre-written collaboration agreements with standardized procedures. Some states are looking at lifting those or waiving those regulations temporarily during the crisis. And also pushing hospitals to allow admitting privileges to nurse practitioners and midwives, which some hospitals do not do. For midwives in particular, this may be important because we are looking at having potentially more women deliver babies in alternative care settings so that they are not in the hospital being exposed to COVID-19. And so this is one area where there's been a growing amount of attention. If you want to look, though, at the nursing workforce that has not graduate degree level education, licensed vocational nurses are another profession where there's some attention. These are typically people who have vocational degrees, less than a community college degree. And in some states, they are allowed to practice under language that essentially says to the greatest degree of their knowledge and training. And in other states, like in California, there are restrictions on what specifically they are allowed to do and not allowed to do. For example, in a number of states, they are not allowed to deliver a medication directly into an intravenous line, whereas in other states, they are allowed to do that. Given the crisis, if states waive that restriction, that would enable registered nurses to focus their attention on the most severely ill patients and free up resources then by having the LVNs backfill the roles that the RNs are moving out of. You get similar stories with respect to nursing assistants and home health aides, who in many states are not allowed to administer medications or do other things like that. But in a home health setting, if they could do medication administration, that again frees up your licensed nurses to go work with the more severely ill patients.
Great. Bianca, are there other allied health professions that you think we need to be thinking about? Is there anything in terms of clinical laboratory or possibly the respiratory therapists? Who else is out there that we should be thinking about? Pharmacists?
Yeah, no, thank you for asking. So an area worth considering too are keeping patients out of the hospital at a time when COVID-19 patients are being treated. So clinical lab techs are actually allowed now to provide care for beneficiaries, Medicare beneficiaries in the home, who are, especially those who are already homebound, rather than have them come to the clinic. That was something that CMS put out, I think just last night, as a restriction that has been removed that allows clinical lab techs who usually work in a hospital environment or a clinical lab setting to change their setting in which they can deliver care. Respiratory therapists also, while they have not had certain restrictions removed yet, are a group that we need to start thinking about increasing their role in providing care to patients with non-COVID respiratory illnesses, provide them care in the home. Because again, that's not a setting that respiratory therapists have really provided care before, but the more people we can keep away from the hospitals, the better. And respiratory therapists can also play a role through providing care through telehealth, or at least even work with patients not face-to-face to help them manage their conditions. But those restrictions on that ability are still in place, I believe. But these are things that are being actively talked about.
Great. And I guess the role of pharmacists and pharm techs are especially important. Do either one of you have any thoughts on that?
Well, I can say that the role of the pharmacist, they sit in the community and they're the ones who tend to help patients already navigate across multiple providers. And a lot of times their focus is on the dispensing of pharmaceuticals because that's what they're paid to do. But we know that their education allows them to do much more than that, including providing actually frontline care for patients. And again, they may be able to play a greater role in keeping patients out of the hospital or out of clinical settings where we need to concentrate our focus on patients with COVID and provide more of that in-community care. They could also potentially be doing more to do screening of patients for COVID. And I don't know that I've heard much talk about increasing their role in that capacity.
I also have heard for pharmacy techs that in some states there are limitations about how many pharmacy techs a pharmacist can supervise. So in both community and hospital settings, that is another type of restriction and scope of practice that could be waived that would enable us to spread our resources more broadly, especially for states that are trying to establish alternative care settings like New York is now and California is, where you're going to need to have pharmacists in these alternative care sites as well. So having more pharm techs available for them to help delegate, to help fill prescriptions, to help deliver medications would help us use our scarce resources more effectively.
Thanks. So this slide that we have up is essentially sort of an area to be explored or areas to be explored. It's almost like a wish list. I want to shift now to what states are actually doing. We have two slides that we've pulled from many different sources. These slides will be available to our listeners as part of the resource packet. And so I don't want folks to feel that they have to take note on every line here, but obviously there's a lot happening. Bianca, can you start us off just by talking about what the mechanism has been that states are using to expand scope of practice and how that differs from the regular mechanism?
Sure. So it's clear through this pandemic that states are using all sorts of mechanisms to be able to mobilize their health workforce. A common measure that we're seeing states use are executive orders that are issued by the governors of the states. These tend to be tend to waive restrictions that are already in place. But at the end of the day, the actual state licensing boards have to make some decisions about how they're actually going to implement the executive orders and make them a reality. In Washington state, our governor has used the mechanism of a proclamation that again kind of mimics what an executive order seems to do, of kind of stating the expectations by the state government about what is needed to be done that our licensing boards then take and run with. We also see, regulations and statutes being put into place also at the federal level as well as the state level, such as being issued by the Centers for Medicare and Medicaid Services leaders to help remove restrictions that are in place by the insurance payers to allow our healthcare workers to work more at the top of their license. Because as much as a state may have certain laws in place that allow our healthcare workers to work in a certain way, if insurance companies put additional restrictions, I mean, that really can limit the way we use our healthcare workers. So it has to be kind of a simultaneous set of moves that are made to make sure that there's congruency between what the state leaders expect and want and what our insurance providers, payers are actually doing.
Thanks.
those are just some examples. And, you know, I think one thing to keep in mind is that many of our healthcare workers, especially in allied health, are not licensed. And they don't have very clear scopes of practice. And so this also goes down to the organization level to have to just make decisions about what they're allowing their healthcare workforce to be able to do.
We've also seen, in Ohio, Ohio is actually a little bit unusual in that my understanding is that they had emergency legislation that addressed most of the things that other states have been doing through executive orders. So, and I'm not sure if that was because the legislature was ready to go and was still in session, or if their constitution sets up a structure by which the legislature is responsible for emergency orders. Every state is somewhat different in that. California, it did not specifically have in the executive order yesterday, did not specifically name the provisions that would be waived. It enabled the different state agencies that are responsible for the scope of practice and other regulations to then have a waiver process. So what's underway in California now is that applications for waivers need to be submitted. They will then go through legal review in the agencies that are responsible for those regulations. And that's a 4 to 7 day process. And then the waivers will be approved or denied and posted on a website so that the public can see what has been approved or denied. So we're going through a much longer process, and I am not an expert on our state constitution, so I'm not sure if that is because the governor wanted to enable it to be a very fluid process that would evolve over time, or if our constitution actually required that this be the process that we use.
So that's a great point. I mean, not only is there enormous heterogeneity across states in terms of what the scope of practice laws are for each profession, but in addition, each state has its own set of laws about how modifications can be made under a state of emergency, or in the case of Pennsylvania, what they call a disaster declaration, or whatever the mechanism may be. So we don't want to suggest that there is sort of a one mechanism for instituting changes. But what's interesting in looking at these states is that they are beginning to copy each other and to replicate good ideas. So I wonder, Joanne, if you could talk a bit about the leading states and what they seem to be doing, not what we think they should do, but what is actually happening on the ground today. And I'm happy to go back and forth between slides if that's helpful. We have a bit of information here on Indiana, New York, and Pennsylvania, as well as Arizona. You've talked about California, Florida, and Kentucky. What is your sense as you look across the states in terms of whether there are states that are beginning to lead in this area and what some of the lessons might be from those states?
I would say that the first 3 states on that first slide that you have for this session are really some of the earliest leaders. They came out with executive orders that were pretty comprehensive, covered a lot of different professions. And what's really notable about these 3 states as well is that they vary a lot in terms of their political climate, in terms of the regulations they had previously, and in terms of the severity of the COVID-19 epidemic at this time. New York has had to move very aggressively given the situation there and how much ahead of the rest of the US they are in severe infection rates and hospitalization rates. Indiana has a growing case rate, but not at the same degree as New York or Pennsylvania. But yet they were one of the earlier states to move forward with recommendations. So it's interesting to see the range of who the leaders are, but what I think is really neat about what they did is that they were just very comprehensive. And I'm sure that they will be adding things as they go along, but they did put a lot of good ideas out there rapidly and are moving forward with a lot of other provisions that are around students and retirees and extending licenses and training and other provisions that really interweave with scope of practice issues to help surge the workforce.
Right, and we will be having a couple of webinars on the issue of expediting licensure, which is probably the main thrust of most of these executive orders. The scope of practice changes seem to be far and few between. Bianca, I wonder if you could comment on why you think that is. What are the political sensitivities? What are the fears around expanding scope of practice? Is there an issue around, a fear that these temporary measures might become permanent? What is your sense of what the conversation is?
Yeah, that's a very good question. I do think that the last point you just mentioned is a big one, is this fear that if you open up the gates now to let people do activities that they were not doing before the COVID crisis, that there's no bringing back in the sheep from out in the field, as one could say. It's one of those things that I think people worry about, the fact that these scope of practice restrictions were maybe in place for the protection of patients, and that by releasing them, somehow you may be providing subpar care for patients. However, all three of us know, as well as many others in the health workforce research arena know, that these restrictions have been put in place not for necessarily the reasons to protect patients. And many studies have shown otherwise, that when you relax scope of practice laws to allow people to work at the top of what they're licensed to do, meaning they are already skilled and educated to do these tasks, that does not provide any less quality care to the patients. And I think there's a bit of a misunderstanding from the greater community about why these scope of practice laws are in place. And so as a result, it makes it a very difficult, sometimes political third rail for some people to talk about relaxing those restrictions. I think sometimes the other challenge, especially for allied health professions, is that the scope of practice really isn't very well defined for many of our workers, because again, there isn't a licensure board in place to dictate what people can do. But we do know what they were educated to do, because a lot of times people are coming from programs that are accredited, and does give them a credential that allows them to do certain tasks. But those credentials can really vary, and the content of the curriculum can really vary across states, across institutions. So sometimes we don't really know how workers are currently being used, and what are better ways for people to be deployed during this crisis. And so it goes back to what Joanne said earlier, which is I think states are learning from each other, and they're quickly trying to learn from each other, but these are not easy things to necessarily legislate.
Joanne, I'll give you the last word, particularly on this question of sort of the patchwork quilt of regulations that exist today, and whether this is, I think COVID-19 has revealed a lot of problems with our healthcare system, a lot of problems with our regulatory and policy frameworks. Do you want to comment on the problems that you think that the crisis has revealed in terms of scope of practice?
Yeah, it's a very pertinent point, Polly, that when you have a crisis such as this, you really do see the underlying challenges and problems with the healthcare system. For the United States, because we have these variations at the state level, for which there's no evidence that the more restrictive regulations produce better outcomes for your population, it's been a logical thing then for states to look at relaxing those or waiving those restrictions in order to meet the very, very urgent care needs. And that becomes a politically tricky thing to do. And, I know our governor, when he did his executive order and press conference around that for workforce, he explicitly said that scope of practice is a contentious issue, and kind of left it to the regulatory agencies to review the waiver proposals that come in, which are going to be reviewed in part based on demonstrated or argued need. So this becomes a broader question, and it will be very interesting to see what states make temporary waivers and then determine that those waivers actually should be held into place, or that there should be legislation in the longer term. There are also other states that have legislation at play right now, such as California. And so this may complicate that legislation, or it may actually facilitate its passage. It's too early to say how it's going to play out.
Well, thank you, Bianca and Joanne. This has been very informative. We're all health workforce researchers, and I'm imagining that we're all making lists of great research ideas here for the future, particularly in those states that are going to be natural sort of laboratories of change to understand what the implications of those changes are when they are made. So thank you so much for joining us, and we will let you go.
Thank you.
Thank you. Thanks for the invitation, Polly.